Hi, this is Zach Fulkerson, and in this part of the critical care curriculum, we are going to be discussing shock. This is our first lecture, and we're going to be going over the definition and types of shock. With that said, let's get going. So before we get started, I want you to think about what your definition of shock is. Does it have to do with blood flow? Does it have to do with blood distribution? Does it have to do with a low blood pressure? Pause the video and try to figure out what your definition of shock is. Once you've thought about that, our physiologic definition of shock is really tissue hypoxia. And it's because usually it's related to poor oxygen delivery, so say low cardiac output, anemia, something along those lines with respect to oxygen demand. So your tissues are demanding a certain amount of oxygen just to function, and your heart, your blood, all of that has to supply that amount of oxygen. And if there's an imbalance in that, that is what we refer to as tissue hypoxia, and that's what we refer to as shock. Now, there's one other etiology that can cause shock, and that is if you are not utilizing oxygen well enough. So sometimes in septic shock, you get mitochondrial dysfunction. Certainly in cyanide poisoning, you get mitochondrial dysfunction, and that can cause shock due to poor oxygen utilization. At its core, shock is inadequate perfusion. That's what we mean by tissue hypoxia in most of these circumstances, is inadequate perfusion, and it is most definitely a deadly state. Septic shock alone has a mortality of around 40%. Cardiogenic shock is at least 40%, and in some cases can be as high as 70-80% depending on the etiology. These are deadly states, and they require rapid attention, which is why we're going through this in the ICU. From a biochemistry standpoint, I want to remind you why tissue perfusion is important. So when blood is flowing to your muscles, to your organs, it's distributing substrates such as glucose for energy metabolism. It's also supplying oxygen. That glucose gets metabolized through glycolysis. It produces a couple of ATP, and it generates pyruvate, which then gets shunted into the mitochondria through the Krebs cycle, and as well as down into the electron transport chain, oxidative phosphorylation, where oxygen is used to generate a substantial amount of ATP, 34, and this is, of course, how tissue, how muscle supply itself. Now, if you have a problem where you're not providing oxygen to tissue, or you're not able to utilize that oxygen, then all of this machinery just goes down. And what happens is pyruvate starts to build up. You have this paltry ATP that's getting produced, and this pyruvate has to go somewhere. It generates lactic acid or lactate that goes back in the bloodstream, and we use that as a marker of poor perfusion or a marker of shock. Now, before we go into the different types of shock, I want to introduce you to Kevin. Kevin is a triathlete as well as an exercise physiologist, and he's doing a VO2 max test. He's on a bike. The amount of work that he's doing is increasing over time, and as he's increasing the amount of work, his VO2, which is his oxygen consumption by his tissue, is steadily going up. Now, at some point, his oxygen consumption, the oxygen that his tissue need is going to exceed what he can deliver, and then he starts utilizing glycolysis, and lactate starts to go up. Now, I want to point out that as lactate goes up, this is our marker of tissue hypoxia, so this is essentially a shock state. This is a deadly state for Kevin if he didn't have a way of stopping this, but of course he does. He can stop this by getting off the bike. The reason I'm using this illustration is to point out that we get bogged down in things like fluids and things like pressors and things of that nature, but we have to remember that there is an underlying reason that our patient is in shock, and if we don't figure out the underlying reason and work to correct that underlying reason, then we cannot get our patient off the proverbial bike, and they will eventually die. I mean, again, shock is a very deadly state. So again, the treatment of shock is to correct the primary insult. And when we do that, we're trying to minimize deleterious compensatory responses. All right, let's go into the manifestations of inadequate perfusion. It's not just a low blood pressure, but usually shock is manifested by a low blood pressure. So a systolic blood pressure of less than 90, a mean arterial pressure, or a MAP of less than 65. These are very concerning to us. But it's not just a low blood pressure. There are other manifestations. the kidneys will stop producing urine output, and a low urine output, less than 0.5 milliliters per kilogram per hour, is very concerning. The brain, if you're not perfusing the brain, you're going to get someone who's lethargic, who's confused. You might get someone who's anxious because of the metabolic acidosis that's occurring. From a pulmonary standpoint, they're going to have an increased respiratory rate that's related to compensating for their metabolic acidosis. If they're in cardiogenic shock, you might have crackles from pulmonary congestion. In terms of a cardiac MRI, you'll often see people tachycardias, some sort of systolic ejection murmur. Skin can be cool or warm depending on the type of shock, and we're going to discuss that in more detail when we divvy up the types of shock. Usually in terms of perfusion, your extremities will have poor capillary refill, your pulses may be decreased and thready. From a lab standpoint, again, lactate is going to increase. This is a marker of tissue hypoperfusion. Creatinine will increase. This is a marker of poor renal function, but this is a very late finding. So if someone is in early shock, the urine output is a much more reliable way of measuring renal perfusion rather than creatinine. Troponin can go up because of poor coronary perfusion. Poor liver perfusion can cause hepatocyte injury with an increase in AST and ALT. And of course, you can see that decrease in bicarbonate from an anion gap metabolic acidosis, which is predominantly from lactate, but also from renal failure. Let's pause again to think about the types of shock. Again, I throw these into two big buckets, hypodynamic and hyperdynamic. This is related to the cardiac index, and I want you to pause real quick and think about the types of shock that you know of and which bucket you would throw those types of shock into. Now that we've thought about that for a little bit, I tend to throw the things with a low cardiac output into the hypodynamic bucket. This includes cardiogenic shock, where the pump doesn't work, hypovolemic shock, where the pump doesn't have anything to pump through, where there's not enough blood for the right and left ventricle to pump, or obstructive shock. I think hyperdynamic is distributive shock. These are things like septic shock or anaphylactic shock, and these have a high cardiac index. So again, cardiogenic shock, you have a low cardiac output because the pump doesn't work. Hypovolemic shock, you have a low cardiac output because there's no volume, and obstructive, you have a low cardiac output because there's something that's blocking you. This can be a pulmonary embolism, this can be severe aortic stenosis, this can be cardiac tamponade. And of course, distributive shock, you have a low systemic vascular resistance. So our pump is working, but we're malperfusing our tissue because we're not able to direct blood flow to particular tissue. Now, before we end this lecture, I want to go quickly into the hemodynamics of shock. So if you remember this is a Starling curve where we have a normal person here and someone in severe heart failure here. Both of these people can be in shock. Both of these people can be volume overloaded. So if any of these people get too much volume or too much preloaded, they will end up being congested. So pulmonary edema, lower extremity edema, things of that nature. Also, if the stroke volume goes down on either of these people, you can be in a shock state. As you can see, someone who's normal has a much more generous margin of error before they go into shock or before they go into congestion, whereas someone in severe heart failure has this very, very narrow window. This is why cardiogenic shock is very, very dangerous. Now, I'd like to do a quick diversion to talk about the effects of positive pressure ventilation on different types of shock state, because a lot of our patients who are in shock are going to require a ventilator. And that's where we transition someone from normal negative pressure ventilation, where you're breathing in and out using your diaphragm, to positive pressure ventilation, where air is being pushed in with a ventilator. So what happens when you get on a ventilator? Well, first, your peak airway pressure is going to increase. That causes the alveolar pressure to increase, as well as the pleural pressure or the intrathoracic pressure to increase. If the intrathoracic pressure increases, that's going to cause a decrease in our venous return, which is going to cause a decrease in our RV preload. Because our alveolar pressure is increased, our pulmonary vascular resistance is also increased, so our RV afterload increases. That causes a reduction in the LV preload. And finally, a reduction in the LV afterload. Now, what this is going to do to your patient is going to vary depending on the type of shock that they're in. And to demonstrate this, we're going to go back to our Starling curve here. So if you have someone in severe heart failure who you put on a ventilator, you're going to decrease their preload. So that increase in thoracic pressure is going to decrease the preload, and that's going to move them, say, from here back to here. That can be very, very beneficial for your patient. And of course, you have to be very careful when you're taking the patient off of the ventilator, because eventually you're going to want to think about taking your patient off the ventilator. Now let's compare cardiogenic shock with hypovolemic shock, or someone who's close to hypovolemic shock over here. So if you have a patient starting over here and you put them on positive pressure ventilation, you could decrease their preload to the point where they fall off of a cliff hemodynamically, and this could lead to a very dangerous state, if not an outright cardiac arrest. All right, so we've talked about the definitions of shock. We've talked about the different types of shock. We're going to go into more detail about the different types of shock in our next lecture, but that's going to do it for our first lecture in shock in this section of the critical care curriculum.